Welcome everyone to the second worldwide webinar hosted by the Smith-Lemli-Opitz Foundation for parents of kids with Smith-Lemli-Opitz Syndrome. Today's presentation, titled Challenging Behaviors with Individuals with Smith-Lemli-Opitz Syndrome in the Time of COVID-19 Quarantine, is brought to us this morning by Dr. Elaine Tierney.
Great. Hello.
Kaylee,
Hi.
Kaylee's going to go over some housekeeping and then I will introduce Elaine.
Yeah, so just a reminder of a couple of housekeeping items before we begin. We sent a form for people to register before the meeting on the Facebook page. I'll send the link to the form again in the chat, and if you wouldn't mind completing the form in your own time, we'll then forward the slides from this presentation and any additional resources. This meeting is being recorded and will be uploaded to the Smith-Lemli-Opitz Foundation YouTube channel. Sorry, yeah. So.
All right. Let me introduce Dr. Tierney. Dr. Tierney is a research scientist at Kennedy Krieger Institute in Baltimore, Maryland, and an associate professor of psychiatry at the Johns Hopkins University School of Medicine. Dr. Tierney is a pediatric and adult psychiatrist with a special interest in autism, genetic, metabolic, and neurological disorders that cause behavioral disturbances. In 2001, Dr. Tierney and colleagues identified that Smith-Lemli-Opitz syndrome is associated with autism spectrum disorder. And in recent years, Dr. Tierney and her colleagues have conducted research that has received funding from Cure Autism Now, Autism Speaks, and the Smith-Lemli-Opitz Foundation. So what I'm saying is that Dr. Tierney is a bigwig. That's evident from her bio. But what you may not know if you haven't had the pleasure of meeting her, is that she's one of the kindest, most compassionate medical specialists you'll ever meet, with a wonderful sense of humor. She's just an all-around lovely person. And we at the SLO Foundation are lucky to have her service on our medical advisory board going back before my time with SLO, more than 20 years. She can correct me on that. Surely no person on the planet knows more about Smith-Lemli-Opitz syndrome and our children's behavior than she does. Welcome, Dr. Tierney.
All right, thank you. Hello, everyone. So today I will talk about extreme behaviors in SLO. I'm going to record it with my mic for Dragon, and because of that, I'm going to the feedback problem even when my phone's on mute. I'm going to close out one of my screens so you won't see me, but I'll again once we get to questions. All right. Okay, can you hear me okay? Okay, very good. Like Dragon just advanced my slides, I think. Sorry. All right, so I have okay, so a document is going to be sorry, I have a PDF that's going to be sent to you that goes over a lot of behavioral aspects in autism, and it's the same strategies that we use for children who have different genetic syndromes, such as SLO. All right, so I just put briefly the definition of autism. I think people know it. The name has changed over time. Some people, it's now called autism spectrum disorder. And its individuals have difficulty with social interaction, communication, and may have unusual or repetitive behaviors. And sometimes you'll hear the words pervasive developmental disorder or Asperger syndrome. It's all just these are all just catchphrases for essentially what's going to be a lot of different disorders. Okay, so in autism, about what 1 in 10 people with autism were able to identify what disorder is causing it, and Smith-Lemli-Opitz is one of them. And SLO, about half of the individuals with SLO, or third to a half, had been diagnosed with autism spectrum disorder when we've done studies. And the reason sometimes it's helpful to have a diagnosis of autism, or to think about it that way, is to get appropriate services. For example, being in an autism classroom, where classrooms are smaller in size and may emphasize visual instructions. And in the classroom and at home, one of the strategies is using a picture board that maybe shows the activities that are going to be performed during the day. And also, autism school programs often have emphasize social skills training, practicing social interactions. Okay, so now I'm going to go, that was just kind of a background about why I talk about autism. Now I'm going to go into what, how to assess severe behaviors. And the PDF that will be sent to you from Autism Speaks really goes over a lot of this as well. So it might be helpful to refer to that later. So when I meet individuals, I try to understand, as a psychiatrist, I try to integrate various components. I will look to see, are there maybe medical or psychiatric illnesses that run in the family, or traits, because that may help me understand if the individual with SLO has some other conditions going on at the same time. And we assess medical conditions, or allergies, like if somebody's hitting their head, do they have allergies or sinus infections? Right, in SLO, we ear infections so often. If you have someone who doesn't usually hit their ear routinely and they start hitting their ear, that's suspicious for an ear infection. Is there gastroesophageal reflux, headaches, dental pain? Seizures don't usually happen with SLO, but if somebody has a pattern of very specific kind of movement, and maybe like an arm or hitting, something like that, we wonder, could there be seizures? But again, it's not very common in SLO. Oh. Okay. Okay, I ask questions about sleep, behavior, energy, appetite, moodiness, irritability, crying spells, difficulty with concentrating, kind of ADHD symptoms. And then I ask a bit about the self-injury. It can be injury with the eye. Is the skin being broken, for example, if somebody's biting? Is there aggression? Is there obsessions where you have to do something? Or the child has to fix something in a certain way, someone's hair, something in a certain room. And are there other repetitive behaviors that are occurring? All right, one of the questions that was asked is, can hitting the head cause injury? And yes, a couple of things that can happen. If somebody's hitting their head, they can damage their hearing. And the other thing that we see, which is very concerning, is you can get a partial or total blindness. For example, I work full-time on an inpatient unit for children who do severe self-injury and aggression, and we have a a girl on the unit now who's blind from hitting. She's 12, and we had a boy who's who was blind by the age of 5. And what happens is the back of the tissue, known as the retina, can come off. And sometimes it's difficult for individuals to be able to do the eye exam and look, but there is an ultrasound that can be performed, an ocular ultrasound, that you don't need a lot of compliance for it. I don't know how many hospitals can do it. I know that mine can. And then self-injury can also cause fractures, lumps and calluses. I know in SLO frequently that there's an area on the hand that becomes calloused because of the mouthing of the hand. And then no one really knows, but we wonder what chronic head hitting might do, considering professional athletes can get a dementia syndrome. Okay, so half of individuals with SLO have had self-injury at some point, including, if we're counting biting of the hand. I think about when I did this about 20 years ago, I think there were, at least half of the individuals with SLO bit the hand. Some didn't do anything beyond that, but others, as we know, have much more severe self-injury. We don't know why individuals with SLO have a lot of self-injury to begin with. I mean, clearly there's something, because, for example, the biting of the hand, it's very automatic. It's just in the same place with everyone. I think of it as a stereotypical, like a syndrome specific behaviors, like something you see in SLO. Like in Rett syndrome, you see the hands being washed like together in front, holding the hands in a certain way in front of the body. What does seem very evident, and I say, gosh, pretty much almost all the children I've seen with SLO, is that some of the self-injury is to communicate, because the spoken language, the expressive language, is not have difficulties. Sorry, I know this is advancing. I have to remember to toggle my cursor back over to Dragon Notepad. Otherwise, it advances my slides when it's toggled in the wrong place. Okay, sorry. Okay, so okay, so the PDF that's going to be sent to you describes this as well. So what we do, we have, like on our inpatient unit, we have specialists who do, they're psychologists, behavioral psychologists who do applied behavioral analysis. And we do behavioral assessments, and we try to assess what is the purpose or function of the behavior if it's not physical or mental health condition. And the physical would be, is there an ear infection, something like that's happening? A mental health condition is there underlying ADHD or bipolar disorder? And even if people do have either of those conditions, they still may have behaviors for other reasons as well, and we try to assess for that. So is it for communication? In SLO, I see a lot of individuals do self-injury when they want attention, such as attention to communicate a need. They want to they want to get something. They want to get their parent to do something. And if they do self-injury, the parent pays attention to them. So that's very often I see that in SLO. Sometimes it may be to avoid something, such as at school, or it can be other maladaptive, difficult behaviors like hitting someone else or something because they want to avoid something. And I ask questions such as, how does somebody do at school versus at home? If they can do well at school, then you can get a sense of how well they could do at home if we can get the behavioral assessment and treatment in place. Okay. one of the things we do is to complete a behavioral diary. You would record what's kind of try as best one can record what's occurring before, during, and after the behavior that happens. Also making notes on the environment, who was there. Was there anything different in the environment? Was a new situation? Was there music on? And how do you think the individual was feeling during that, when it was happening? Okay. One of the questions I had was that somebody was having, even in a good situation, the self-injury had increased. So self-injury can increase during any level of sensory or agitation input or physical activity level. So if somebody gets excited, I mean, if they have a tendency to hit themselves and they get excited, then that might increase the hitting right then out of the level of excitement. Often sensory input can be overwhelming. In our first study that we published in 2001, I found that children with SLO had more sensory difficulties than children with autism, children with Rett syndrome. That really very high level of sensory, both, which I think of sensory input. Individuals who often are bothered by sensory input of some type also seek out sensation. Like you might want to listen to something crinkle, but then really hate other noises. And in SLO, okay, so so the communication strategies that we use on our inpatient unit and we can use with SLO is trying to get what we call functional communication, meaning what communicating appropriately. Instead of hitting yourself, it's better to have maybe a picture. So sometimes we'll do picture boards. You have different like squares that have certain certain things you want. It could be a toy, it could be a video, different things. It could be mom. And on our unit, we we work to try to figure out what the best means is. For some individuals, it's a board that has maybe one picture to start with, and that can be built upon. If somebody throws their device, then maybe it's better to have just a board with pictures. But some individuals with SLO, for example, will have an iPad or other device where there's a picture and you touch on it and it says it. And you can, some individuals can toggle through different layers of a communication board. And then, so that's helpful, like if an individual wants to tell you what they want. The other thing that's difficult in SLO is for individuals to understand what you're saying. I mean, usually individuals with SLO can understand a lot more than they can say or communicate. But sometimes children with SLO need extra time to process the language, to process what's being said to them. And also, picture boards can be very helpful. For example, if you're going to go somewhere, you could have a board where you have a picture of the school or a picture of the grocery store. And you can have, if you're going to do a couple of things during the day, you can have them in order, or you can present one. And then when it's getting closer to the other time, present the next picture. Sometimes that can be helpful for transitioning. Okay, so in general, addressing with SLO, increasing structure and routine can be helpful, meaning you have it kind of try to maintain things the same from day to day, since individuals with SLO have so much difficulty with transitions. Sometimes giving alternative sensory experiences. so that such as swinging, jumping. Some people use a trampoline, although that can be potentially dangerous too. Or some people use maybe a trampoline that has a little bar you can hold on to, so you can jump up and down, like a small one, but still hold on. Um, uh, Deep pressure. Occupational therapists are individuals who are very good at figuring out kind of what sensations somebody might be able to tolerate and also like. Okay. Okay, so some of the things, because of the sensory overload that can occur, individuals with SLO can have a lot of behavioral difficulties when you're in loud places, public places, things that are difficult to avoid as you go through the aspects of life. So sometimes if you can get an individual to keep headphones on, which sometimes they will if it's something they like enough, such as a DVD, a movie, or maybe favorite music, having that on when you're going to somewhere where it's going to be loud and difficult to integrate, that sometimes can be a strategy. I know one person told me about going into toilets where they have the automatic toilets that flush. At least we had that in the US. There's a little like a sensory eye covering that with a Post-it note, something so it doesn't go off when you're using the toilet. And then if somebody does, if an individual, sorry, the problem I'm having with the slides is when I have to bring my cursor over to click back on PowerPoint, my Dragon's advancing it faster than I want. Okay, so sometimes what we do for self-injury is use physical restraints. We do that on our inpatient unit if somebody's, for example, hitting their head because of the dangers of that. And a strategy is we often can start with like full ones. We have sleeves. Let me go back for a second. So one of the things we see a lot on a unit is individuals who do self-injury also do what we do self-restraint. For example, they might sit on their hands or put their hands in their pockets because it seems like they don't want to hit. They do, but they don't seem to want to because they're also trying to keep themselves from doing so. So on our unit, we do physical restraints, and now that sounds like a bad word, but that is what it is essentially. Not that we're tying anybody down, but we mean wearing things that help prevent the self-injury from happening. For example, arm sleeves, where you have a sleeve, and then there's little pockets in the sleeve, little small pockets where you can put metal stays, which is just to make it a little bit stiffer. And what we're often able to do is we start with that, and we only leave it on for a certain amount of time, but we can find that over time we'll take out the stays so that you get more and more flexibility in the arm where you can eat and do things. And then we get to the point where a lot of individuals, they can wear, it's just the cloth sleeve and they don't hurt themselves and they have full use of their hands. But if you take off the sleeve, then they start doing self-injury again. So they're able to understand that when they have the sleeve, the self-injury doesn't happen. So that's something a behavioral psychologist can work with you to try to see if that might be helpful. The other things we do to help protect tissue, skin, it doesn't help with the hitting, but biting of the arm or the hand is you can buy Kevlar sleeves. So Kevlar is like bulletproof material, and you can buy on Amazon. You can buy sleeves made of Kevlar and gloves. And I saw one last night. I looked that covered the glove and all the way up past the elbow. And then if somebody mouths and that's a difficult thing because of the tissue breakdown that can happen from the saliva, is you could do potentially like a waterproof material underneath. I guess it could be neoprene or maybe a kitchen glove, something like that to keep the moisture off, and then have the Kevlar sleeve over it. Someone asked me about picking of the fingers, and yes, in SLO, there's so many repetitive behaviors and picking at, and we see in autism in general, picking at sores, finger picking. Some of the strategies we've done for that is, yes, you can do gloves, including a Kevlar glove. The other thing is we've had some individuals where we find that actually they want, because they had the sensory input at the finger, you can do other things, have it like a vibrating toy or a vibrating device, like a vibrator at the tips of the fingers, and that sensory inputs can sometimes be helpful for individuals. I've listed a couple, and you'll be getting all these PDF, my slide PDF. A couple of different articles. There's one called Spark for Autism that describes a lot of what I've described, and some from the UK. And then some sources for help. You can always contact me, and I'd be happy to talk with you and any doctor who's trying to intervene. At Kennedy Krieger, we actually have an inpatient unit where we do take people from across the U.S., sometimes internationally, but payment for that with insurance might be more difficult. But I list there, and then I did the other information I took off of the National Health Service website. Okay, so let's see. Okay, and then, so when I'll talk about medicines. So what we usually try to do is we have a behavioral psychologist who helps try to figure out the function of the behaviors. And figure out a behavioral treatment. But very often individuals need medication as well. For example, in our inpatient unit, pretty much everyone ends up with doing a combination of both. And I always talk about families. I'm a pediatric and general psychiatrist. So of course I might be biased toward medicine, but behavioral treatment is always the first intervention. But if somebody is suffering, or the family members, it's impairing the life of individuals, that's a reason to use medicine, as well as is somebody a danger to herself or others, such as doing self-injury that puts the eye at risk, risk of blindness because of the self-injury, or they're not learning like how to interact in school and home life appropriately. And I always tell families that all medication are trials, and it unfortunately is trial and error as well for finding a medicine that might be helpful. And then I always tell parents it's up to them to decide if they see enough benefit that they think it's worth the risk. I say it's fine if they want to go off the medicine. It's not my decision, it's theirs. And one has to weigh the potential side effects versus concerns and risks, and that it's always a trial. All right, so the medicines that tend to, so what I do is I try to figure out the behaviors that are presenting. Do they also look like other conditions such as attention deficit hyperactivity disorder, bipolar disorder? And the medicines that we often use for really target aggression and self-injury the best are neuroleptics, also known as antipsychotics. They actually do treat pretty much all of our psychiatric disorders. They're not, though, our first choice for a lot of disorders because of the potential side effects. But they are very good at treating aggression and disruptive behavior and self-injury. Particularly pretty much none of our other medicines really can help the self-injury as much. And some of the ones, and the name in the brackets is the scientific name. So if you're in the UK or elsewhere, it's the trademark name. The first one is going to may be different than the scientific name. And I've just listed some of the ones that we use. There are a couple of them that tend to increase the 7-DHC. So in SLO, 7-dehydrocholesterol or 7-DHC it gets converted to cholesterol in the body when the body makes cholesterol. And a number of our neuroleptics can impair that and increase the 7-DHC, particularly Abilify and Haldol. So we tend to avoid those. But in some individuals, if you've tried other neuroleptics, you still could go to those and use those because the benefit tends to outweigh any difficulty that we see with the 7-DHC levels. And the potential side effects to be concerned about is you can get temporary muscle stiffness with the medicine. That frequently that you can treat with diphenhydramine, Benadryl, or other medicines, and that's more a nuisance side effect. But the more concerning ones are a movement disorder that might not go away over time. For example, some mouth movements. But again, I mean, right now, particularly when people are younger or until you can get maybe behavioral psychologists to help you target the behaviors, it can be just keeping someone safe from doing damage, from hurting, going blind or breaking, doing tissue damage. In that case, I would say, well, yeah, use a neuroleptic. Because you're kind of weighing the risk versus the benefit. And you can also get a neuroleptic, a malignant syndrome, where one has a very high, you can get a fever and tissue breakdown, look very ill, and blood pressure change, and you can die from it. So I tell people if they're on a neuroleptic and someone looks very sick, they have a fever, stop it and see your doctor. So, often what I've seen when I've talked with families and they've been treated with neuroleptics, but they're not working, is the dose is tiny. Individuals with developmental disabilities tend to use the same doses as adults because their livers are pretty healthy. So often when I've seen individuals, they just haven't been treated with an adequate dose. But a lot of our neuroleptics in the US, at least, you're able to get a blood level, which tells you how much an individual has in their system. And sometimes pediatricians or doctors who are nervous about prescribing, if they can see, oh, okay, the blood level is low, let's go up on the dose. And I'm also happy to talk to any doctor about it. Okay, so obsessions and compulsions are something that we see so often with SLO, and it's such a severe problem. So the definition is, an obsession is a thought that comes to you that you want to do something. For example, an obsession I might get is, I just don't know if the front door is locked. And it's bothering me, I want to go check it. And the thought, if you're thinking it, that's the obsession. And the compulsion is when you actually go and do it. So like I'm actually go and check the door. So we call it obsessions and compulsions. And there's a disorder, obsessive compulsive disorder, OCD. So I'm going to use that acronym. Okay, some of the compulsions that we see with SLO frequently are opening and closing doors or drawers, turning light switches on and off. There's also maybe a sensory aspect to the light switches or other things that are making noise. I've seen individuals throwing things away. Like I may have a container that's half full of something. They have to empty it and then throw it away. Touching things repetitively, collecting things, right? Collecting twigs or having to hold things. I had one patient who has to hold a Coke bottle in one hand and a certain toy in the other hand, always. And like a lion, although over time we were able to get her to hold a picture of a lion on a piece of paper rather than the animal. And behavioral psychologists are amazing at figuring out kind of what other things can be helpful. And it does appear in SLO that I found in individuals with SLO as they become older, on like adolescence and adulthood, that the OCD tends to get worse. Or maybe that's what I'm noticing more than other things. Maybe when they're younger, they're doing more self-injury. And I'm thinking about that more. Okay, so I see a lot of anxiety in SLO, and often it's socially related anxiety. There's a condition called selective mutism, and that's when an individual can speak, for example, in certain settings, but they choose not to speak in others, or they don't speak in others, such as at school. And one little boy with SLO who was speaking, and then at age 5, he stopped speaking, and when he went to school and wouldn't speak in school. But we were able to get him to whisper in school, or he was whispering. And then he spoke loudly enough, although he still did it in it sounded like a whisper, but a loud one. So anxiety, we definitely see a lot of that. Cognitive behavioral therapy is a type of behavioral therapy in which one tries to stop oneself from doing it. And a behavioral psychologist can use some of those techniques in individuals who can speak and or they're able to try to stop themselves to do something. So on the bottom of the slide, I just mentioned there's different antidepressants that we use. Sometimes you'll hear it called an SSRI, or serotonin selective reuptake inhibitor. It's a family of medicine. In the US, if we use the name Prozac, most people know that one, which is fluoxetine. And then out of all of them, the first one I list escitalopram, which is called Lexapro in the US, and Cipralex in the UK. I tend to choose that one because it's relatively fast acting, but it also doesn't interact with other medicines as much. It's not broken down. A lot of the other ones are broken down. Most medicines are broken down in the liver in the US, in the liver. And Lexapro doesn't interfere with other medicines that are broken down in the liver. I do caution families to be very careful if there's a family history of bipolar disorder, or if the individual with SLO has bipolar disorder, because the antidepressant can worsen the disorder, or if it hasn't presented yet, you have a biological predisposition, meaning it's kind of in the body, you have the genes for it, an antidepressant can make it show up, can make bipolar present. Another class of medicine that I use are the benzodiazepines, like Ativan, lorazepam, or diazepam. That can help anxiety. We do tend to use it a lot in our inpatient unit, even in individuals who are on neuroleptics, just to take the edge off. These also do treat seizure disorders as well. We can use it as a daily medicine. It says benzodiazepines capitalized. I'll fix that. That was a command to my dragon to capitalize something, I think. So we also use lorazepam, Ativan prior to medical procedures. And I can talk to any doctor about that. And actually, before I'm going to revise the slides a little bit, and I will put in the the dose of the lorazepam, and I'll also put that into the transcript from the meeting today, because it's based on weight. And some of the things I do when I talk to people, if they're on medicines already, a lot of medicines can be moved around, can be put into split doses, doing strategies such as if individuals are in a day program or school and they come home and that's the really difficult time, then maybe I'll target taking the medicine prior to, as soon as they get home. Sometimes we use Benadryl, diphenhydramine. There it is. Okay, so the lorazepam, did have it in here. Okay, so we use it before travel, sometimes before medical procedures such as getting the vaccine, just to help people be calm. And then I put the dose of how much we usually give. And then I need at least 4 hours between doses. That depends. It depends on how much, if you're going up to that amount of 0.025 milligram or 0.01 milligram, then you have to wait for 4 hours. What I recommend to families, if you can get your doctor to prescribe this, is to try it ahead of time, like during a time of stress a little bit, so you can get a sense of, how much does the individual need? And that might depend as well as if they're on other medicines. So I would try it ahead of time, a number of times, prior to going for something like a blood draw or a vaccine. So I looked for, I mentioned earlier that I assessed for bipolar disorder or ADHD. Some of the so for the mood disorder, like bipolar disorder, also known as manic depression, is one of them. And the other is depression. So the antidepressants, I just list some of the other ones that are some of the SSRI I had in the other slide, but also Wellbutrin, is in another class of medicine. And I will make these slides a little bit better before I send it again. Some individuals may have a seasonal component to the winter. And you can use, in that case, a light box, a box that has a light that has a certain a certain profile can help with depression. You do have to, again, be careful if somebody has bipolar disorder that it doesn't activate them. Exercise can also be helpful for depression, and it generally helps anxiety. Like I say to every single patient I have, no matter if they have a developmental disability or not, or a parent or child, is exercise every day. It helps to calm an individual, usually lower anxiety and depression, and be able to integrate. And in individuals with SLO, getting the exercises can be a lot of sensory input, swinging or jumping up and down, something like that, that then is helpful for both mood, anxiety, and sensory regulation, and can lower self-injury and aggression. I've mentioned bipolar disorder a couple of times, but I haven't defined it. So bipolar disorder, also known as manic depression, is an illness, and it's in about 1 in 100 to 1 in 25 people have it. And people can feel angry or irritable. Other times can be overly happy, although some people can swing into just like okay and irritable. But these are kind of cyclical mood disorders that doctors can try to tease out and help with. A lot of individuals with SLO look like they have bipolar disorder, and other individuals with developmental disabilities. Even if there isn't a family history, there seems to be some kind of mood dysregulation. And often when we have diagnoses, it's all, I mean, it's diagnosed by just talking to somebody and trying to look at a grouping or constellation of these syndromes. We don't have blood tests that can diagnose any of these disorders. It's all just talking to people, trying to understand them. And often if somebody has symptoms that look like something, like have a cyclical component or a lot of irritability, I tend to use the same medicines that we use for bipolar disorder. Some people will use the bipolar disorder diagnosis and some won't. They might say diagnosis like disruptive behavior disorder. Just kind of, you can get all kinds of different names for it. But the most important thing is that you identify that there is that kind of cyclical or disorder, and trying to use the medicine that we typically use. And those medicines are medicines like lithium. Lithium is, it works great. The problem is you have to get blood levels with it. So that can be a real problem with SLO. So instead, we might use Depakote or Depakine, divalproic sodium or divalproic acid. That works. It's great. And you don't really need blood levels with it. The blood levels can be helpful to know how much is in your system. Like the neurologists often don't get blood levels because they're treating seizures, if you're treating seizures. But with behavior, I like to get a level so I can at least kind of know when I'm at therapeutic, because it varies a lot from person to person. And you have to get to a certain blood level to get it to actually work. And then I've listed some of the other medicines that happen to also treat seizures, but they treat bipolar disorder as well. Okay, so we see ADHD and SLO, particularly in the children who are more mildly affected. They can be, oh my God, so incredibly active, just really fast, running. Girls who have ADHD, typically developing girls, as well as girls with SLO who have ADHD, tend not to have as much of the high activity level, but they still have the difficulty concentrating. And I also see an SLO, even if somebody, not so sure they have ADHD, but I think that inattention can sometimes be due to delayed processing time. So if you're asking somebody to do something, sometimes you have to wait a little bit longer to make sure they've heard it and their brain has processed it, what they might call auditory processing. I've listed the medicines that we frequently use with ADHD, methylphenidate, and some of those are trade names for different methylphenidate products. Have a certain way that it comes out of the capsule, like Concerta, so they'll have slightly different names, but those are all the methylphenidate family. And then there's a Dexedrine Adderall family. And then there's a different class of medicine that's not a stimulant, but they're known for being high blood pressure medicines, but they also are helpful with ADHD, such as clonidine and guanfacine. And Strattera is an antidepressant that's used for ADHD. Someone asked about what can be used for vaccines and procedures. So you can use a couple of things. You could use there's a product like Bauer Pain Ease and other we call skin refrigerant sprays. It's a spray you use and it numbs the skin in 10 seconds, 3 to 10 seconds. Now, I know it's not going to help look when you see a needle coming at you, but if you can, I think Kate would be fine with me saying she just had a Juki immunized. They were able to drive up and have it done. And she distracted him with something and he didn't see the needle coming and got the shot okay. So you can use a paint, something like a skin refrigerant spray, or you can use a numbing medicine like lidocaine, or a combination of both. You put the lidocaine on like 30 to 60 minutes ahead of time. It may be hard, like, I don't know if the skin refrigerant ones are painful at all going on. I haven't used that, but I do definitely, there's some people for procedures, they'll use a combination of both of those. If we're talking about going for a blood draw instead, sometimes the lidocaine products can make it harder to see the vein if somebody is a tough stick. And also if somebody's going to go for a blood draw, drink as much, if you can get them to drink water in the morning. I know sometimes they'll say fasting, but usually it doesn't mean fasting water, although you can check with the doctor to make sure there isn't some unusual blood test that is being performed. But usually a lot of water, because that helps to plump up the blood vessels. And then I just listed something I found in the UK, the NHS, National Health Service website that talks about lidocaine. All right. Okay, so I'm going to go to my phone and come into the meeting on my phone. All right, hello. Hi. Put my phone over so I can see all your faces and my larger screen behind. All right, gosh, so nice to see you all in person. So, any questions for me? And everyone's muted at this moment, so you need to unmute yourself if you have a question. All right, and you might have.
Good morning, Elaine. Thank you
hi.
very much for those comments. That was really helpful to me, and I bet for other parents here. I'd be curious to hear what advice you have for parents when their child is becoming aggressive and wants to engage in some sort of combat with the parent or the siblings. We've dealt with this from time to time with Juki, with attempts to bite, attempts to pinch, and I've come up with some ways of keeping him safe and keeping the rest of the family safe. But I'm curious to know if there are standard recommendations or advice that has come from all of the conversations that you've had with SLO parents over the years.
Is it more than attempts? Successful.
Yeah, and some of these attempts are successful.
Yeah.
Kate reminded me to include. Thanks.
Yeah, one of the and as people think of other questions afterwards, after this talk, email them to me as well. What I'll do is I can answer some of what I know, but I will also ask my behavioral psychologists for a little bit more help on this. One PDF that's going to be sent to you has quite a bit of information about assessing behavior. I think it's like 60 pages or something. And I'll read through that. I just found that last night. I hadn't seen it before. It's from Autism Speaks. So the behavioral psychologists try to figure out what they try to do is figure out what happens just before the behavior. Sometimes the aggression very often is for communication, like, or is bothering someone. Often when a sibling comes in the room, like if a younger child or younger sibling comes in, they're making a noise, so they're interfering. So sometimes it could be, I think of it as, it might be a sensory aspect, that there's noise now or interfering, so they may be aggressive. If that aggression worked, like the person left the room, then maybe the aggression is going to work again if they do it again, and it reinforces that behavior. So behavioral psychologists come up with treatment sometimes might be some individuals, it might be a basket hold, or they have to go into a little room by themselves, padded rooms, something to come up with a behavioral aspect. For individuals, I often use the neuroleptic family, the antipsychotic family, to help lower that irritability and the aggressive tendency. Sometimes the aggression can be related to something they want to do with that individual, like doing a compulsion. They want the person to do something with them. So it can be all kinds of reasons. Any other questions? Let me mention too about the self-injury. What do we do when someone is self-injuring? I mentioned the behavioral psychologist figuring out like what might help. The other thing we do is we do, if the self-injury is strong enough, we try to block it. Like if somebody's hitting their head, we may block that with the hand, although try to not give them other attention. And again, I know it's really hard. I mean, it's easy for me to say these things, but it's another thing to do them in real life. So that's why if you're able to get a team, like a behavioral psychologist, if you can get that, and a psychiatrist or neurologist or developmental pediatrician, someone, or even pediatrician to help with medicines as well.
Great, thanks. Does anybody else have any questions? Do they just want to raise their hand, or yeah, Nicole?
I do. I don't know if I missed it since I'm joining almost an hour late. I apologize, but has anyone talked about doing neurotherapy? I know I posted this a couple days ago, but has anyone had any luck, or has anyone tried? Maybe Dr. Tierney knows anything about neurotherapy for our kids.
I don't know what that is.
You meant neurofeedback. You were
Yes,
talking about.
yes.
No, our unit doesn't do that. I'll have to ask my psychologist and investigate that more. Just Googling. EEG.
I can share the link that you shared on Facebook, Nicole.
Perfect.
Tierney. Yeah.
Thank you. Yes, I'll read about that. Okay. Oh, so immediate feedback from brainwave activity. I'll have to read about that, and I will get that I will supply that information in the transcript once it gets sent. That's going to be sent to everyone. Any other questions?
Julianne raised her hand.
Yes. Hi. Thank you, Dr. Tierney. Really interesting talk, and I actually learned a few things which I had not attributed to SLS just yet. So a question about the obsession on compulsory behavior. You just mentioned when it goes to aggressive behavior, maybe distract them, but not too much, so not to reinforce that. If it's just little things, would you recommend just let our son is 4, so just to put that in perspective, would you recommend just letting him do, like, I mean, if he needs to hold a Matchbox car in his hand all this time, would you recommend letting him just do it if it keeps him calm, or would you suggest to deviate the behavior if it's not in an aggressive matter?
Yeah, that's a great question. I guess I think I like what you're getting at is like, do we stop it so it doesn't become even more? I would try to give him other things as well. At least deviating from that car, give him a different toy, something like that. Because you're right, once he gets stuck on the car, if he doesn't have that car, than it worsen it. And you're right, when we do treat OCD in individuals, let's say like an adult like me, if I have OCD, and I'm like, for example, we had a child who had a contamination fear. So he wouldn't bring his backpack in the house because he thought it had germs from school. So, but he was able to bring it into the door in the garage. And the next day, a little bit closer and closer and closer. And we do think of behavioral therapy as actually changing the brain wiring, the brain chemicals. Yes, so if you can kind of try to avoid getting into these patterns as much as possible, that would be good.
Thank you.
I know that Julie had her hand up as well a minute ago.
Yeah.
Julie.
Yes, hi. I thank you for this presentation. This is great. My daughter is an adult. She's 35 and doesn't have the kind of combative behaviors, but it's more non-compliance or more passive aggressive. I wonder if you've seen that as children age, or is that just her?
A lot. I mean, in SLO, they're so stubborn. I mean, out of all the genetic disorders I worked with, I think individuals with SLO are the most stuck and stubborn and non-compliant, and just kind of, So, so our behavioral psychologists would work on getting a reward system. One of the first things we do when we hospitalize someone, well, you can do it outpatient too, is figure out what do they like. Is it going to be a food reward, which is maybe a tiny piece of a cookie, something like that, or is it going to be a reward where you get screen time? Most of our children, they can, no matter what the developmental disability level, we end up being a reward of watching a video, like something on the screen time. So often, if we can, they're going to be non-compliant, but if they do something in a certain sequence, and maybe they see a picture where they're going to need to do it, you do these certain things, then you get to watch screen time. So yeah, I see a lot of that in SLO.
Okay, thank you.
Any other questions?
Jennifer?
Hi, thank you.
Hi.
So my son Gage just turned 7, and we struggle with school in terms of he does things on his own terms. When he's taught something, if he doesn't think it's right, he will fight to say it's wrong, to where he has a breakdown. And I'm just wondering, the slow processing side of that, is there any helpful hints to maybe get through that? Because I struggle with Gage trying to get with school because of his stubbornness. And some of it is it Gage? Is it the age? Is it how he's in class? He learns behaviors pretty quickly from the other kids, and obviously they're disabled, so he follows their patterns. And for me, it's how is this recognized, and how do I help him with the school aspect of it? Because he really, when you talk about stubborn, I mean, my child is the epitome of it.
Poster child.
I mean, we really are struggling in school because of the fact that he wants to do things on his own terms. He can understand like 2 + 3 = 5, and he can understand 3 + 2 = 5, even though he doesn't associate they're the same. But now we have this common core math that they'll do 5 = 2 + 3, and he has a meltdown because he does not associate it and does not understand. And there's nobody that can give me answers to help with, how do I help him with that? I mean, we obviously can't not do common core math, but he is struggling something fierce.
Well, glad you brought up the school aspect. So in the law in the US, and I hope it would be in other countries as well, is they have to accommodate disabilities. And they'll have a behavioral psychologist or a psychologist go into the classroom and figure out what kind of behaviors are happening and create a behavioral protocol. So maybe in this case, the behavioral protocol is that he doesn't get common core math.
so they can opt out of that, because I have fought with his school. I mean, this year I'm retaining him this year because he just hasn't gotten it. I think even from kindergarten, he actually hasn't gotten it, but the school has fought me continuously to the point where I've contacted the Department of Education because we've done a behavior process. They took it out because it's more work for them and they don't want to do it. And now they're wanting to put one in place with the ridiculousness of him biting his hands and things like that. It's not really addressing the issue. They're more skirting around it. So I get no help from the school.
I don't know. Yeah, behavior, unless you could work at home.
We are working from home.
Oh, yeah.
Still teaching at home.
Yes, thank you. Outside of school time, I don't know if doing like flashcards where you had 5 equals and then the other 2 and moving them. I don't know. I haven't. Yeah, I don't know. Sorry.
Jennifer, the school can get creative with IEPs, and you don't have to just accept, the first round of whatever suggestions they're telling you. I don't know if you've ever had an advocate in there with you.
I have one. I do. We have used her continuously. The school just seems to fight me on everything. So they're not trying to be creative. And especially with COVID and all of this stuff going on, I understand, but I still need help, and they fight tooth and nail. So I feel like I'm a little lost and confused on, they're not trying to help my son. And honestly, I have sent an email to the principal and the Board of Education saying that they're failing my son completely, and it doesn't seem to matter.
Do you have a lawyer?
Yeah, I was going to say a behavioral plan, even a behavioral plan that's attached to an IEP is a legal document, and they are required. And a nice, gentle letter from your family attorney might help, or at least get them back on track with formulating a creative plan for you.
I think California. Oh, go ahead, Kate.
I was just going to say, I think that skipping or altering the math to a more traditional format rather than the Common Core, which is really hard for, any kid that struggles with math, let alone a kid with SLO trying to do Common Core math. I can't even imagine that. I can't figure it out. And I think it would certainly make sense to say we need to approach math in a totally different way, maybe in the traditional way that we learned it, because he has an IEP and this is an area where he really struggles. And that seems like a pretty easy place to start, at least for helping him feel he needs to have success, right, at school.
Right.
And he's just going to get more and more frustrated if he's not getting it.
Right.
The Common Core just comes at it from too many different angles, which I don't think is helpful for a kid with SLO.
But they're not willing to change that.
Right. That's what I was saying. Here in California, we have Disability Rights California. I don't know if you have an organization similar, but they help free of charge and help me with legal and attorney to make them do their job, to force them. They're not being willing. You're going to have to stronghold them.
I'll look into it. I don't think we do. I mean, literally, I've contacted everyone who I can possibly contact, and I seem to get nowhere. And it's just a constant struggle. So it's like, you're failing my son, and it's not right.
Yep.
What state are you in, Jennifer?
Nevada.
How much do schools contract with private tutors? We had supports in the school, so we never had to explore, but do any of the school systems, Elaine, work with private tutors in conjunction, more one-on-one? Not therapy, but kind of a supplemental for school, and I guess I don't know who pays for that and all of that, but.
So we do, like, for example, in our inpatient unit, everyone who's being discharged has somebody who, usually we can arrange something as an outpatient. Sorry, not as an outpatient, but someone who goes into the home and they're behaviorally trained. So perhaps you mean by, in that sense, they could tutor if a child is able to do something like our academics. Like we have on our unit, every child, no matter the level, we end up doing some academics, so they're learning a task. And one will hear the term applied behavioral analysis, ABA, and it's used in a couple of ways. There's the ABA type, what I described, where we figure out what's reinforcing the behavior and what's causing it. And then the ABA where you're doing a task over and over. So we do arrange for people to go into the home and assist with putting doing that academic of the tasks. So it could be at all levels of behavior. And one of the things we work on in the unit, the good thing about having academic is then we have, for example, if somebody is matching something, we may have somebody, they're doing that for 10 minutes and then they get a reward. So they end up working for, half hour at a time or however long, depending on their level and age, but they're doing something or they're folding something. So they're doing something that they're getting a reward. It might be a little sticker that goes on the board, and at the end you get something. So yes, we can get someone in the home to help implement that protocol, or also to teach academic skills like math if they're able to do that kind of work.
Do you know of, Gage is actually not diagnosed with autism. However, tomorrow we have a neuropsychological evaluation, and I would not be surprised if he did have autism or ADHD. However, my insurance does not cover it. So I have applied for programs here in Nevada that seem to not help as well. So is there any idea on how to make it less expensive? Because I don't actually have I don't have access to ABA therapies.
Okay, so if he can get the diagnosis of autism, he might be able to get additional services. Let me just, in Nevada, let's see. So and a lot of states, they have what's called an autism waiver. So if you can get that diagnosis, then you're able to get additional services in the home and additional hours.
Okay, thank you.
Yeah. So I will, one of the things I'll send through today, the document I'll send through our article and a couple of our articles on the rate of autism in SLO. Actually, I'll do the one that has the higher rate, like 50%. So in case that might be helpful to you.
Thank you.
You're welcome.
I think we also had a couple more people with their hands up. Galen, were you one? You wanting to ask a question?
Was answered. Thank you.
Oh, perfect. Thanks. And Miguel?
Yes, hi there.
Hi.
Well, first of all, thanks very much for your time, Dr. Tierney, and thanks for all of you that organized it. My question is, and I've noticed here some, our child is 10 years old at the moment, but I've seen some of the kids, represented here are a bit older. And I suppose I was wanting to know, what can you tell us about the path of these challenging behaviors and, particularly self-injury and obsessive behaviors? What is the path as our children go into adulthood? I mean, we know, obviously aware that puberty brings its own challenges, but beyond that, what have you seen, or what can you tell us about that trajectory?
Okay, so of course, a lot of individuals I've seen have been treated with medicine, so it is hard to tell. But my sense is a lot of the self-injury is less as they get older, in some individuals, and it seems like the obsessions and compulsions are more I see more as they get into adolescence and adulthood. But other than that, I can't really say specifically because sometimes if individuals are bad about their own medicines, it might be just secondary to the medicine. And it also varies so much from individual to individual.
Of course. Okay, thank you.
Anybody else have any questions they would like to ask Dr. Tierney?
This is Andy. I just want to more comment on something that Dr. Tierney said about exercise. Our son Juki is 20 now, and a lot of this has to do with COVID, but for perhaps the last 6 months or more, I've taken him out for a 5 mile or longer walk every day. And that has helped to, I think, exhaust Juki, regulate his behavior, give everyone else a break from his obsessions and carrying on. And so if you have the room in your workaday life to go on long walks with your child, it's something that's really worked for us and that I would recommend.
And in the era of COVID, it's sort of the only activity we can do with him because he won't wear a mask. So we can't take him anywhere other than for long nature walks.
That's good. And Andy, would you please get the information from the chat and put that into a document? I see that someone said through an attorney information for Nevada, and I think the neurofeedback info went through there as well. So.
Absolutely. We'll make sure to grab all of the resources that are shared in the chat and get those to you.
Can I ask one more question? Sorry, I have a ton, but I will limit them. So the processing side of the delay, can you go into a little bit of detail about that? Or is that, again, a syndrome thing? Is that my stubborn child thing? How do I help him get out of that? From class to class, he squirrels and loses focus. And it takes maybe 5 to 10 minutes for him just to reevaluate or reassess himself just to be able to do the work. But that's for every simple subject for him to be able to function. Is there any help or tips on how to help with that?
So he's at home right now, right?
Yes.
And so do they switch from like math to reading?
Yes.
Okay. And then for the first, he's kind of just a little agitated or restless in the beginning.
Yeah, he constantly fights. He doesn't want to do it. And I have a tutor from in the morning for, that's not school related, to help him. And he fights tooth and nail that he just doesn't want to do it. He has a bad attitude. He'll get on and give her attitude like, I don't want to do it. I don't care. And
okay. Yeah, it sounds like he really needs like a behavioral plan and behavioral reinforcement that if he does something, he gets rewarded. And a lot of places like even Kennedy, we're doing things are all via Zoom, like assessment. Well, I'm not sure how they do that, but they do Zoom visits. So what you could do perhaps is have a picture where even though he can talk and such, but it's just kind of visual is nice that it's going to be this class and then this class and this class. You can put the time so that might help. I think a lot of time the transitions make people with anxiety feel really uncomfortable. So sometimes knowing ahead of time, okay, I'm going to do that. And then the next thing, that sometimes can help using what's called picture board.
okay, we use that now. It doesn't seem to help him. He's a very stubborn child.
Yeah, these transitions are hard. Yeah.
Thank you so much.
You're welcome. All right, any other questions? Thank you very much.
And I'm sure we all agree that this has been another wonderful and extremely helpful talk. And if there are no other comments or questions, if everybody wouldn't mind unmuting themselves now, please, just so that we can give a nice warm thank you to Dr. Tierney.
Thank you.
Thank you.
Bye-bye.
Thanks, Elaine.
Thank
Thanks,
you.
everyone.
My pleasure. Nice to see you
Thank
again.
so much.
Bye-bye.
Thank you very much.
Have a great Sunday.
Oh, thank you.
Bye-bye.
Appreciate it. Bye-bye.